I got some more editing to do on this one, but that's all right.
There you go.
Yeah, you promised us snake bites, didn't you?
Yeah.
You sure did. All right. Well, let's see. Everybody that is here, let's do a little bit of quick housekeeping. First off, remember, keep your microphones muted. Unless you want to say something, and then you can unkey your mic and ask a question or make a comment, and then remute yourself so that your background noise doesn't, interfere with everybody's listening to the lecture. You can also chat in the chat room. Dr. Phillips is really good about keeping one eye on that. This is Dr. Donald Phillips. He is our Associate Medical Director. He is very, very helpful with Dr. Frame. He's the one who's responsible for keeping up with most of your progress that I drive him crazy, sending, every step of final exam. You finished your skills testing, you finished your quals, all of that goes to Dr. Phillips for him to review, and then he marks the note. That's why you get those double notices. Another notice that later says reviewed by medical director. That's Dr. Phillips. So he's here tonight to talk about snakebite, which he promised us last week or whenever it was that we had you, sir.
One of those.
And one of those. And everybody give him your strict attention. Remember, you do have to participate if you need credit. Some of you are here because you're professional MD roundtablers, and that's okay. But if you need credit for MD roundtable or chat, then I will be watching to make sure you participate. Mr. Waller, if you would please hover your mouse over your name in the participants box and go to more and click rename, and then put your course ID, like 300E or whatever you're in, right after your name, so I don't have to look it up later. It's hard on me sometimes to look from roster and roster. And I see Janelli, Raffelt, and Carly Grace. Does that mean, I don't even know, do we have a Carly Grace?
No, I'm sorry.
Janelli?
I need to, I'll change that. It was for another meeting.
Okay.
I apologize.
Not a worry. I just looked at that name suddenly and thought, I don't know who that is. But most of you, I know your names, but then I have to look around on the rosters to figure out which class to go look you up to give you credit. That's the reason I like you to put your course number afterwards. All right. That having been said, I'm going to mute my microphone.
Okay, so I do have the chat box open, and I'll just tell you that first off, to begin with, a lot of this information comes from a pharmaceutical company named BTG. Don't ask me exactly what it stands for, but they are the people that make Crofab. While I am on their speaker list because I went to this conference for them, and that was how they got us there and paid for everything, I have not been paid for this presentation, and I have never received a check from them. So just so that we have all of that out in the open. So let's start off with venomous snakes of North America. Okay, there's not really that many in the grand scheme of things. For those of y'all that are in North Texas, and I did not put this in the presentation, there is an excellent resource on Facebook, if you're on Facebook, called What Snake Is This North Texas? There's two of them. Somebody stole the name and started a joke group, and then there's an educational group. So just look for the educational group. But on that page, you can actually send in your questions. You can send in pictures of snakes that you're not sure what they are, and they will help you to identify them. And they ask that only the people that are administrators actually identify which snake it is. So these are the four different real types of snakes that we have in North America. We have the rattlesnakes, the copperheads, the water moccasins, and the coral snakes. And actually, the copperheads and the water moccasins are in the same family. So we'll come to those in a minute. Now, I'm not going to burden you down with Latin names for these things because I can't say them most of the time anyway. So let's start out with talking about the coral snakes. First off, they're usually somewhat small, up to about 3 feet, but some up to 5 feet have been caught. They're very colorful. They are a member of the cobra family. They have small non-retractable fangs, so they don't flip back and forth like other venomous snakes in America do, and they're in the front. Now, I've read references that say that those fangs are in the back and that it's hard to get bit by these. First off, they are smaller snakes, so their mouth doesn't open quite as wide, this kind of wide as the other vipers. But you can still get bitten, and because of the way that their fangs are designed, they usually have to sit there and chew on whatever it is rather than being able to strike, envenomate, and pull out. Their toxin is a neurotoxin. It is not a myotoxin, which is what the other vipers are, and it requires a unique antivenom. That one is not easy to find, but there's only about 100 bites a year, and most of those are in Florida. Now, Chris, I'll tell you right now, if you go to that what snake is this, they're going to tell you do not rely on that little rhyme. Red touches yellow, kill a fellow. Red and black, poison lack is another version of it. And they will post sometimes numerous pictures of coral snakes that are coral snakes that do not necessarily follow that. Now, in this picture here, you see I actually got you a picture of each different one of these species, but there are variants, and there are some that are normal variations that are just an individual snake that doesn't necessarily follow that pattern. But as you can see, the Arizona coral snake tends to have broader bands for all of their colors. The Texas one is kind of in between, and then the one in Florida has very small yellow bands. So bottom line is, with any snake, if you don't know what it is, don't pick it up. And if you do know what it is, sometimes don't pick it up. It's better to just leave them be, and they will tell you over and over on this what snake is this, that the snakes are not out to hurt you. They do not want to hurt you. They expend a lot of energy making venom, and they want to save that venom for when they're hunting, when they're trying to get food. So just keep in mind that they are not trying to hurt you, and if you leave them alone and just back away, they're going to leave you alone most of the time. So the coral snake, I'll tell you, if somebody gets bitten by one of those, they're usually going to know it. And in that case, you need to try to contact poison control to find out who has an anti-venom, because since it is so rare, it's actually hard to find the anti-venom. And a lot of times you're probably going to have to go through a zoo to find it. There are some other resources that poison control can hook you into. If you happen to be in the Florida area, they have so many exotics that the fire department actually has a unit called Venom 1 that can also assist with trying to find anti-venom for snakes that are more rare, including coral snake. So that's all I'm going to say on the coral snake. Did anybody have any questions about coral? Nope. Okay. So North American pit vipers. Now in this group here, okay, these are the most common, and there was a pie chart. I didn't bother to put it in here that shows that about 50% of envenomated bites in America are copperheads. However, most of the deaths are due to rattlesnakes. And then the other thing that you'll find out is, since all of these pit vipers have a common lineage, they have very similar venoms, which means similar anti-venom. And we'll come to that in just a little bit. So on the left, you have the rattlesnakes. In the middle, you have copperhead. And then on the right, you have some water moccasins. And we'll talk a little bit about each of those, not much. So pit vipers, 98% of reported envenomated bites are from pit vipers. And then down here at the bottom, the coral snake, crowfab is not indicated for that. Now, even they put that on their slide. This is a slide from BTG. And I'll tell you, when I went to that conference, that the toxicologists that were in the room were like, don't rely on that. Okay, so it's a common thing, and most of the time it does work, but it doesn't always. So let's talk about the Western Diamondback. This is by far the most prevalent. This is the one where, especially in anywhere in the south and the west, you're going to see mostly western diamondback rattlesnakes that are going to be the ones that are biting. The common thing to think about with them is that they have the black and white tail along with the rattles. Okay. Things about head shape and all these other things are nice, but for the most part, most of the time, we're not going to see the snake, and I don't need to see the snake. So just kind of keep that in mind. They also talk about the anal plates, and is there one, is there two? You know what? The thing is not going to flash me that. I really don't care. So as an emergency physician, was it a snake or was it not? That's pretty much it. If they've got two fang marks and they look like they're envenomated, hey, that's a snake bite. So we're just going to leave it at that. Here's another example of a western diamondback. You can see there's quite a bit of variation sometimes in the color, okay? And I'll tell you that when we went to their facility, and you'll see some pictures of the facility, we were not allowed to take pictures, but there are some pictures that they allowed me to use. They have some interesting colorations on some of these, some of them very, very colorful, very vivid colors. Just keep in mind that there's a lot of variation in the color, so you can't really go by that. So the Mojave rattlesnake. Now this one is interesting, and it's interesting because while all of these that we're going to talk about that the antivenom works for are hemolytic toxins that break down muscle and blood, the Mojave rattlesnake also has a neurologic component to it. It's a neurotoxin as well. And we'll talk a little, remind me if I don't bring it up, the experience that they had at the CroFab facility with a Mojave rattlesnake bite. But we'll come back to that in a minute. So the Mojave rattlesnake is a lot more difficult to find. Mostly it's actually in that Utah, Nevada, California, Arizona quadrant right there. But they have been sighted in Texas, but I don't know exactly where. And there's an example of Mojave rattlesnake. Looks very similar to a western diamondback. However, it is a somewhat smaller snake. So the eastern diamondback, once again, very similar. Notice the only real difference is on the tail. It doesn't have the black and white stripe on the tail, but this is a similar rattlesnake, and you can see its distribution. Next one is a timber rattlesnake. And timber rattlesnake is also a smaller one. Notice it doesn't have the huge diamonds on the back, but it does have the black and white tail, and they all have rattles. That's the common thing with these. Now, I will tell you that in Texas, the timber rattlesnake is considered to be an endangered species, and so you're not supposed to kill them. However, we won't talk about that beyond that. This is the cottonmouth or the water moccasin. Okay, they call it cottonmouth because of the white coloration inside of the mouth. There are times, especially on the what snake is this, where you'll see pictures and it will be identified as a water moccasin or a cottonmouth. And I sit there and I struggle with the differences sometimes. They are from the same family, and so a lot of times they have a very similar pattern. The one thing that is really kind of distinctive about the cottonmouth is that they describe its pattern of color as pixelated. So rather than being smooth colors in between, it's like it's pixels, and so it's kind of blocked off. Now, Chris says that they're mean, and yeah, they can sometimes be somewhat aggressive. However, that's usually after they have been attacked or they perceive that they've been attacked. And there's a cottonmouth there. There's another example, and with that one, you can really see the pixelation on that pattern. It's not smooth. Now, if you notice, there's kind of a triangular pattern to the colors on the back of the snake. And they're pointing out that the juveniles have a yellow tail. So here's another water moccasin. And then there's a view that I don't ever want when I'm in the water. So these are the copperheads. Now you'll notice that this also has kind of a triangular color pattern. They describe that as Hershey's Kisses. And I can see where they get that from. Once again, though, the color, especially on some of these species or examples, can be very, very similar, and I have trouble telling them apart. And once again, it's not important. It's not really important that we know if it was copperhead or water moccasin, because they all have the same antitoxin or anti-venom. So Chris says, or David says they're friends. Yeah, they do actually. I still don't want the venomous ones right up next to my house because I do have kids, but I do have copperheads I know that are in my yard. And as long as they stay away from me, I stay away from them, we're all good. And just like Chris says, we can be distant friends. And yeah, and Reed, you bring up an interesting point. You know, there's if you do go to this what snake is that, they will have a lot of times where you'll see the snake and you're going, I'm not sure what that is, and there is actually a diamond head water snake or diamondback water snake, and so you know, those are sometimes confused, and sadly sometimes we end up killing snakes that are not venomous, and they are rodent control. And somebody asked, and I've seen this multiple times, including at the conference with BTG, where they said, you know, if you've got snakes in your yard, what can you do to keep them away from your house? And the answer is make it so that it's not a friendly environment for them. Make it so that there's not some place for them to hide right up next to your house. So that means keeping your flower beds cleared out and things like that. So anyway, that's kind of the bottom line for that. Another example of a copperhead, once again, you can see the Hershey's Kisses. And then this one you can see is a juvenile, and it also has a yellow tail. Once again, it's in the same family as a water moccasin. It's just a different one, a different species. And so they do share that common characteristic and even circle it. So that was for that part. Here's another copperhead. And I'm thinking that some of my presentation must have gotten lost. Let me escape out of this and make sure that I get everything for you guys. Okay. So we'll go back to it. Apparently it shuffled some of my slides. So once again, this is copperheads, and these are, if I believe that it actually points out there's one, there's two, three, four, 5, 6. Don't believe there's a 7th one in there. No, there is. There it is. So as you can see, it's difficult sometimes to see some of these things. So Carlos asked a question about, is there a reason why Texas has so many venomous snakes or such a hotbed for venomous activity? And actually the answer for that is that it's a big state to begin with. And so that is one of the really big questions. So I don't know if that answers your question or not. Get to the right place here. So let's talk, and I lost the chat window and everything. Got to see if I can. if you notice here, this is
Dr.
North
Phillips,
American.
we still don't have a screen.
Oh, okay. Is that got it there?
Were you looking for a map of envenomations by state?
Yep.
You're good then.
Okay. So as you can see, actually every state in the country has venomous snakes in it, with the exception of Alaska and Hawaii. And they actually point out that every state except Hawaii has recorded envenomations. Now, I'm not sure how that happened in Alaska, if it was one that was brought up there as an exotic or what, but every state does have this potential. Obviously, if you're in New Hampshire, Vermont, or Maine, it's not very many. Rhode Island also has only 3. North Dakota is probably a good place if you don't like snakes. But just keep in mind that this can happen in any state. So let's talk a little bit about the anti-venom. So you can see the timeline back in the 1880s when the work on this began, and we're actually looking at back in 1953 was when the first snakebite anti-venom was produced, and that was a Wyeth, and that actually was in use for 47 years. And so even when I was a resident and even through my time with the Air Force, we didn't have anything except for Wyeth. Now that is actually from horse serum, and just because of the immunogenicity of it, we did have a lot of problems with people having acute allergic reactions. And so it was something that was somewhat difficult to use. And it was the dosing was based on the degree of envenomation and how bad the patient was, and it was very difficult to use. I can say that I've only seen that used one time, and the big thing was that you had to test the patient and see if they were going to have an allergic reaction by giving them a test dose before you did anything else, which of course slows everything else down. And a lot of times those patients ended up still having problems and having to have fasciotomies and some other things. At that point, snake bites were considered to be a surgical trauma patient. And so times have changed now, and it has to do with the fact of CroFab being a totally different product. Now, I'm not out trying to sell you on CroFab or anything, but there are some things that are unique that make it a much better product and very easy to use. So the way that this works is you have this venom that is in the tissues, and so by it going into the blood vessel and then attaching to the antibody fragment. And when we say fragment, it's a fragment of the antibody, and we'll show you that in just a second, that actually comes and binds to the toxin and makes it so that it's no longer active. And then you end up just urinating out the antibodies or having it come out in the stool. So it's a very different mechanism. The Wyeth one was an intact antibody that had a lot of issues with it. So the way that this is produced, they actually collect the venom from these different species of snakes, and I'll talk about that again in a second. They actually then immunize sheep with this. The sheep have a lot fewer antibodies that are antigens that end up in the product and being a problem for us. And then you can see the next part is they remove part of the antibody. That's that second part, removal of the FC fragment. And so they use an enzyme, papain, that goes in there and cleaves that apart. And what they will do is that then they remove that FC fragment completely, and they're left only with the antibody that then binds to the venom. And I'll come and talk about that in just a second. So the way that this works is that they have venom places in both Utah and Florida where they will extract venom from these snakes. The facility in Utah has 1,100 rattlesnakes of various species that are indigenous in those areas in the Southwest United States in one place. 1,100 of them, and they are checked every day. They have people that are dedicated that go in and look in on each and every one of the snakes individually, and they make sure that they have food when they need it, water, that their cage is clean, those sort of things. And then once a month, they will extract venom from each snake. So each snake is only used for extraction one time per month. They have their own vet that takes care of them, and and I thought that this was interesting. All of their snakes are wild caught. They are not using any captive breeding program, and that was because they want to maintain the same venom pattern and the enzymes, or I'm sorry, the proteins that are in that venom that are in the wild. They don't want to limit it and narrow it down to just the ones that are in their captive breeding program if they had that. So once the venom is extracted, then it's freeze dried, and then it's sent from either the Utah facility or the Florida facility to Wales to this company there. They then process that, and what they will do is they will take part of that venom, and they will use that to ensure that it's proper strength and everything, and then they are going to use that for further processing that we'll come back to. The rest of it is then sent to Australia, and you're going, why Australia? Well, the reason that they use Australia is that they have a very, very protected sheep herd there, and since it is such an isolated country, it's hard to bring things in and out, and so it makes it a place that's easy to keep their herds very distinct and very pure. So that's why Australia. After they inoculate the sheep, then they take some of their serum and then they send that back to Wales, where what they do is that they will then use this to further to then take the antibodies out of that serum. Now, what they've done with that remaining part of the venom is that they take that and they will use that to coat the inside of tubes that then hold on to the venom. Then they're going to run, after they have cleaved off that part of that antibody, they're going to run the sheep serum through these tubes that then will bind only the antibodies for that part of the venom that they have made. Then after they do that, then they're going to wash the tube out so that only those antibody fragments are left, and then they chemically will use something that will then cause the venom and the antibody to separate from each other, and they're left with only the antibody. And then at that point, they fly it to Baltimore, and then it's put into a freeze-dried form and then put into the vials, and then it's shipped out. So if you ever have a question about why does it cost so much, that's why, because there is so much involved in just producing this. I wish it was a more affordable product, but it is what it is, and there is a lot of human labor involved in it. So this is, I don't expect you to understand this at all, mostly because, well, I'm not sure I do, but this is part of what they go through with ensuring that they have the proper proteins that they are targeting. And so you'll see that there are, the top left is actually a gas chromatograph of a venom from one of the diamondback species. And in this case, it's actually an African species. And they're looking at the various spikes, and then you'll see that in panel C, they've actually isolated a few that they want to then direct their antivenom towards. And then down in the bottom left is actually the antibody or the antibodies and where they're targeting. And then panel D is showing that they actually do find binding of the antigen and the antibody to each other where they want it. So it's a very labor intensive process. So this is actually the gas chromatograph of the venom from the 4 different species that they're looking at. And you can see some common spikes in there. You can see some things that are unique about some of them. And so just understand that this is the sort of thing that they're looking towards. So Carlo, I'm back up since I didn't quite hit that one at first. Why do they use sheep? Well, here's why. While it would be nice to be able to do something, and actually you're thinking about a cloning sort of thing, kind of like we do with TPA, that's actually not the same thing. Okay. First off, producing those things is usually from candida, it's from a yeast. And in those cases, we're looking at the same product all the time. The problem is with snake bites, the venom may change over time. So, and even within the same species, when they start doing these collections, there is a variation from snake to snake in where those protein spikes are. And so as a result, you have to have a different antibody based on what is most prevalent. And that is also why they don't want to have a captive breeding program. They catch these snakes wild. They bring them into their facility. They're there for, I want to say that they said it was 90 days before they are even considered to be part of the venom collection. And if for some reason they are sick or something like that, then believe it or not, they don't euthanize snakes unless there is some really serious medical problem with them. But if they catch one and it's not fit for the envenomation program, they're actually going to keep that snake there and take care of it for the rest of its natural life, which I thought was rather interesting. They felt that after bringing them in and having them in a captive situation for even as little as 3 months, that they would not be suitable to go back out into the wild. So interesting. And that's actually an excellent question. I'm not sure who was busy at his shifts there.
It was just a private conversation going and he hit the wrong thing.
Okay. William, that's an excellent question. And you know what? The guy to answer that particular question about are they chelated out of the bloodstream or excreted would actually be a Dr. Strength. And he is actually one of the folks, you'll see his picture in a little bit. He's actually been with this company since they started before 2000. And so I think that he would probably be the right one. Now the venom is collected the same way that you've probably seen on TV shows before, where they milk the snake. And what they do then is that they actually will pool that venom from several snakes and over several days, and then they will actually do this gas chromatograph that you see there. They always maintain the same species. So if you're at the Utah facility, they're using Western Diamondback every time. If it's a Mojave, which they don't have that one on here, but it's a variant of the Western, they're always doing the Mojave together so that they keep them distinct. They don't pool the species together and send those together. They actually have the species of snake all separate, and they just get the entire venom that they get from the fangs that then they send to be processed in Wales and then in Australia. I don't know if that answered your question or not. I don't believe that the sheep are getting more than one of the venoms at a time when they're doing the inoculation. So then here's another example. You have the whole venom at the top there, you can see, and then when they have the FAB captured toxin, so in other words, after they've done their processing and they have the antibody, this is actually the areas that they're capturing the antigen. This is the antigen areas that they're targeting with that. And then you can see down at the bottom the ones that are not being captured. So those spikes are not being grabbed by the antibody. So here's a little more about the incidence. You've seen the similar chart, and this is just from a different source and different year. And then here's the pie chart with the amount of different species bites. Copperhead is by far the most common, and then unknown, in other words, we don't know. And that's the part that I tell you, I really don't care. Okay. Cottonmouths are a very, very small part, and then rattlesnakes make up 20%. So they also have noted that there's been a 243% increase in the number of bites reported to poison control in the past 20 years. And I think at some point we probably have talked about the T's of snake bites, you know, testosterone, tequila, t-shirt, those sort of things. There's a whole list of those things, and they are actually, for the most part, very accurate. Tattoos, toothless, those sort of things. And it tends to be that people are usually doing stupid things. A lot of times they're intoxicated. I can tell you that the Boy Scout camp that I was medical director for a number of years, we had a scoutmaster, sober scoutmaster, who said, "Oh, there's a rattlesnake. I'll teach the boys how to handle rattlesnake." Yeah, the correct answer is you turn around and walk away. Instead, he tried to pick it up and it bit him on both hands. So, and April to September is the most common time for these. So, toxicodynamics. You don't need to know that fancy name. Just what you need to know about this is that the venom effects can happen very quickly, or sometimes it can be delayed. It depends on where the venom ends up. Is it in fatty tissue, or is it in the muscle? Is it right near a blood vessel? We actually had a kid 10 years ago at Possum Kingdom Lake Park that died, that he stepped on a rattlesnake, a small rattlesnake, while he was out at the park there, and he got bit, and it essentially went into a large vein in his leg. And before he even got to Children's Hospital, he had essentially died. So, you know, it depends on the location, the amount of the venom, everything. There's so many different variables, but there is a difference in those things, and how much of it remains in the body may tell you that you're going to have some delayed effects. So it really is kind of time dependent and dose dependent. So here's a list of just the clinical effects. And so you have local, systemic, and hematologic. You know, for us, of course, the biggest thing is that we're worried about the systemic and the hematologic effects. Hematologic effects can happen rather quickly, but it basically, in the case of this child that I was telling you about, it manifests with the flight crew that picked up the kid at the scene saying that the child was already having blood coming out of the mouth and nose, and he was bitten on the ankle. So it can sometimes be very bad. Here's some of the local tissue effects. It can cause blistering. It can cause bleeding in the skin. It can cause a lot of swelling and edema. There is blood in the muscle tissues there. You can see the fluid the serum is weeping out from the area as well because it's so swollen. And like we talked about, you can have progressive signs and symptoms. And so rather than worry about is it minimal, is it moderate, is it severe, these days because of the product that is available as an antivenom, we really don't need to worry about that. Really, it comes down to a question of, is it envenomated? Is it not? Pick one. If it's not envenomated, then you just need to watch and make sure that you made the right decision. But if they are envenomated, then just give them the Crofab or whatever antivenom that you've got. Wyeth still makes one, and there's a competitor that's coming out to Crofab as well. It's not available yet. So the consequences. So you have a lot of local effects, and systemic effects really are, for us, the biggest thing that we worry about. We worry about them having cardiopulmonary collapse. That's really the big thing. Later on, rhabdomyolysis is a fancy term that means that the muscle cells are breaking down, and all of those things that were in the muscle then have to be filtered out through the kidney. And if the kidneys can't handle it, especially if you're not hydrated, then that can cause kidney failure and death. But keep in mind that every bite is different. There is no one snake bite that you can say is how it's always going to be. So, pre-hospital snake bite information. So, to me, and I'll give you a good reference to look for these so you don't have to write down all this stuff, but these are the things to avoid at all costs. Tourniquets, extraction devices, electric shock. Yes, believe it or not, there are some people that will put, of all things, a stun gun across their bite and shock themselves with it. Anything prophylactic, blood products, antibiotics. I can't imagine doing a fasciotomy, but some people would. Don't cut these, because all that you do is you make a bigger necrotic area. Ice or heat, definitely don't do those. And NSAIDs. Keep in mind that this is a hematologic toxin, and so it's going to want to break down the red blood cells. It's going to make the platelets less sticky. It's going to make them bleed. NSAIDs will do that as well, so don't do that. I said never try to capture or kill the snake. I don't need to see the snake. I don't need to see anything other than something that looks like a fang mark. You only have to have one. And the area looking like a bite. Okay, if somebody tells me that they got bitten by a snake and they have a puncture wound and some redness, and especially if it's oozing from the bite site, to me, that's a snake bite. That's all that I need to know. But definitely don't bring the snake to the ED. That child that died, the hospital that I was working at, some guy shows up, and I could hear him when he showed up. Hey, I've got the snake that bit that kid. I'm not a police department. I really don't care, and it was still alive, and it was in a cooking pot. And so we called the police and said, let them deal with it. So they took it out into the parking lot and let it go. And hey, snake's doing what it's supposed to do. So the only time that we really need to know a species is if it is an exotic species. So a pet of somebody's. I don't know why somebody would want some of these things as pets, but there are people out there that have some horribly dangerous foreign snakes. And so usually they will know the species, and they will know where the antivenom is if it's something that they need that. So that's something to consider as well. Chris, we can certainly try to talk about it. I'll tell you right now, I am not an expert on that. So here's an example of when somebody put ice on one. Obviously, it's an older photo. Don't put ice on these, okay? So pre-hospital snake bite information. Time is tissue. I hate these things. Time is brain, time is muscle, time is heart, time is everything. It really is. So, and it's not that you necessarily have to rush everywhere, but you need to recognize whatever it is and do something in a timely manner. Timely manner sometimes involves saying, okay, I'm going to wait and see what happens with this. But just keep in mind, if it is a snake bite, they do need to get the antivenom before the venom has a chance to act on the tissues. Remove constrictive clothing. Take a picture every 15 minutes while you're en route and show the bite area and all the swelling, and mark it. Take your pen and put a little mark where the edge of the redness and swelling is. That way you can see it in the pictures better. Elevate. Now before we were told to put a tourniquet on of some sort, a loose one, a venous tourniquet, and then drop the extremity down so that it didn't get into the central circulation. What they found is that causes more problems later on. So you actually want to elevate this. Try to keep them calm and still. You don't necessarily have to immobilize it, but try to keep them calm and still. And really, most of EMS care for this is supportive. So IV, put into oxygen if needed, airway support, pain medicine. Okay, don't give them Toradol, but it hurts. Give them pain medicine. Treat the patient that you have in front of you. And if you haven't already committed the phone number for poison control to memory, it's the same throughout the United States. It will get you to your regional poison center, no matter where you call in the United States. That number works. Now, this is an example of the chart from BTG about how to treat these. And so you can see the assess a patient, check for envenomation. Is an apparent dry bite? Yes or no? And then you have to observe still for 8 hours, even if you think it's a dry bite. And then you have to keep reassessing the patient. So even though you go to a scene and you find somebody that they said, I got bit by a copperhead, and you look at it and it looks okay, you know what? You really need to come to the hospital, because we really need to keep an eye on you for up to 8 hours. Once again, the time is muscle sort of thing. Time is tissue. As soon as we know that it's something that, hey, that really was an envenomation, then we need to do what we need to do with that, whether it's just observe for more time or go ahead and give antivenom. And then they talk over and over about this thing called initial control. So what you want to do is if you're giving the antivenom, you got to give it in a large enough quantity that you no longer have progression of that erythema or swelling so that it gets bigger and bigger. You got to get that initial control, then start reassessing to make sure that you stay there. And that's obviously not for you guys to worry about, but it is for the inpatient side. And actually, in the days of CroFab now, a lot of times these are actually observation patients. They come in, they get the antivenom, they get it on a scheduled basis, and then they go home within 24 hours for most of the bites. So this is what they were talking about again. The initial thing is getting initial control. That's that first part on the left-hand side there. And they're talking about 4 to 6 vials to start with. That's always been the starting dose for CroFab. Now, here's an interesting thing to keep in mind. The dose for pediatrics is the exact same. It's just in a smaller volume of fluid. So it doesn't matter if it's a 3-year-old that stepped on a snake at a park, or if it's a 30-year-old that weighs 400 pounds. The dose is the same. Keep that in mind. So they actually are really kind of pushing giving a total of 12 vials throughout their stay. And there's been several studies where they have shown that the tissue damage and the disability afterwards is much better if you just go ahead and give them the extra vials later on. Now, it's a huge expense. I'm not going to deny that. But we're talking about long-term disability. We're not talking about, 10 days. We're talking about the rest of their life. So resources. This is lifted straight out of the BTG stuff. So local poison center, once again, same number, 222-1222. And a lot of times, and I have my EMS, they're supposed to call on every overdose or possible overdose, no matter what. And the big reason is these people will follow up. If they recommend staying at home, and sometimes they do with our patients, if they recommend staying at home, they are going to follow up with the patient. They are going to call them and check on them. So I do encourage you to call the poison center. I don't care how many times you've dealt with a Tylenol overdose or a TCA overdose. Just go ahead and call, because they are going to do that follow-up. They'll follow up in the hospital. They will call us and tell us, hey, you know, Medic 22 is bringing you a patient that got bitten by a snake, and here's what we recommend. So, you know, it's a good safety net. It's well recognized. It's a very good process. Here are some other resources, and so these are for the CroFab product directly. Then this is actually a free app that you can get. It's for both iOS and Android, and this has an emergency room side, so this can tell us what to do about these, but it also has a first responder side, so it can tell you what to do. You don't, I'm a firm believer that you should look up your protocols, especially for things that you're not doing every call. Just look it up, make sure that you're doing everything. You know, it's been said that there's a reason why the pilot checks a checklist when he's landing the plane every time, and that is he's on the plane too. So I believe that we should have that same attitude. Let's just go ahead and check the checklist. It doesn't take that long to do, and you can keep it on your phone, and it will help you with those things. It does have, like it says, a quick dial to the poison center. I accidentally almost hit that one today. So it will do that. It also has a way for you to take a photo or take your photos of the bite. And then even for the general public. So this is made for everyone. And it does also have a thing in there where you can look up what kind of snakes are likely in your state, no matter where you're at. And then, and it will show you pictures just like this of those snakes as well. So now we're at the tail end. So just real quick, while we still got a few minutes, this is the Utah facility there. Okay, that gentleman in the top left photo, the one in the far right is Dr. Strength. You'll see him several times. He's a rather older gentleman, I'll put it that way. But he also is very, very knowledgeable, and I really enjoyed talking with him. And so he's open to any question at all. There is no stupid question. But you can see there's a picture of them doing the venom extraction in the top right. They have their own vet that is dedicated just to their facility, and then they do the processing. They certify that the venom. How would you like to have that big jar of venom that she's holding there? No, thanks, I don't want it. And then they have the support where that's actually part of their feeding program. So each one of those little racks on each of those racks, so there's, you know, seven rattlesnakes in each one of those racks of 7 trays. There's one snake in each one of those trays in that rack. And you walk into the room there and they start rattling. And it's a little bit unnerving when you first walk in there. Here's our vet providing some medicine to the snake. And then they have this one vet that approves whether or not they go into the venom extraction program. And then here's how they handle the snake. So they actually get them to crawl into this tube, and then the head comes out of the end, and that's how they are able to handle them without having them wrap around them. And there you see one of the serpentologists handling the head and getting ready to do the extraction. And there's the actual extraction itself. Yeah,
That doesn't
David,
look so voluntary to me.
No, it's not voluntary. None of
So you
these
said
things volunteered.
voluntary bite procedure.
Well, they're producing something there for them to bite, but yeah, it's not.
Uh-huh.
It's but the
If I
snake
was
has
a,
to open
s-
its mouth. Now,
if I was a
here's
snake, I'd want to bite too.
so here's an interesting little trivia point. That facility has been open now for 20 years, and in that time frame, they have only had 4 of their handlers get bitten. One of them, it actually the snake bit through its own lower mouth to get the handler. And then there was one where the fang came out of the side of the mouth a little bit to get the handler. The last one that they had, they said, was a Mojave, and they didn't think that it was that serious. And they're actually on the University of Utah campus, very close to the University of Utah Medical Center. They were going to walk the guy over, which they just drove him over in their own car and got to the ER. And as they were walking in, he was already having trouble walking, and he couldn't keep his eyes open because his eyelids were so weak. But within a matter of a few minutes after they started the anti-venom, he was back where he was moving everything and didn't have any weakness anymore. Yeah, David, I started working in a rural area where I actually did get about 5 envenomated bites a year that I took care of every year. We probably had 15 to 20 bites a season. And we had one of our doctors that was insisting that we should have the little suction cups, and he always would try to open them up and try to extract the venom that way. Just don't do that. You just cause more tissue destruction. So you can see here, daily collection is not that much. And so you can see that the crow fab requires on average 400 to 600 grams per year for each venom. So they do have to have a large number of snakes in order to produce that amount. And then, like we talked about, they actually will analyze each sample, and they'll make sure that it has the appropriate spikes on the gas chromatograph, and then they certify that, and then that's what gets sent to Wales. And so here's the entire team. Now, that particular room we went into, and behind Dr. Strength on the left-hand side, you can, over there is a Western Diamondback that, honest to God, it had to be probably 8 inches in circumference. Huge snake that had the most brightly colored pattern that I have ever seen. And they were like, yeah, that's probably our best eating snake. We never have to worry about that one eating. So, and once again, these guys, the serpentologists, which are these 6 on the right, they know their snakes. They know each individual snake, and they stay with the same ones all the time. But 7 days a week, somebody is in there, and they open each and every one of those bins. They check to make sure that they don't need their cage clean. They make sure that they have water. On feeding days, they check to see if they've eaten or not. So, these folks care a great deal for each of the snakes. And I asked a question at the facility: if you had a process or something happened where they got out, are they microchipped so that you can tell which one is which? Because they have some of them that have a red tag on them, and that means that those snakes are highly aggressive, and so they're supposed to take special precautions with those snakes. And Dr. Strength said, and I still remember, and you probably have heard me say this, that is an excellent question, and I am so glad that you asked that question. We do not have that. Most of our serpentologists know their snakes based on their pattern, and they can identify them. But we probably should do something like that, so that if there's an earthquake and they get that, and I'm like, an earthquake, I don't want to be in this building if there's an earthquake, for sure. But that's one of the things that I took from that particular program was Dr. Strength made a point of saying, I want you to ask questions, because when you ask questions, I get to learn something, and I want to keep on learning. So how many do they have in residence at one time? At that particular facility, they had 1,100 rattlesnakes that were there all the time. And every year they try to bring in new snakes from the wild, and it's kind of an ongoing basis. And the reason is, once again, they want to be sure that the venom profile is as it is in the wild. And that venom profile will change over time. And so they want to be sure that that's up to date. So, but that's a great question. What else? As you can see, we're at the end here.
About 9 years ago, my Weimaraner got bit by a rattlesnake. About a 5 foot long rattlesnake, pretty good. Wasn't 8 inches around, that's for sure, but it was a nice, hefty, fat snake. We didn't realize because it got her on the ankle, and we couldn't tell at first if it was dry or not, and she was fine for about the first 30 minutes. And then she rapidly went unconscious. Her ankle just suddenly ballooned up to the size of a deflated basketball, I guess. And she was breathing like 80, 90 times a minute. And we had to carry, she weighed 90 pounds at the time. And my husband had to carry her into the after hours vet because, of course, it was on a Sunday afternoon. And in between that, the anti-venom and the 3 days of IV fluid so it didn't destroy her kidneys, it cost us over $2,500 9 years ago to save that dog.
Yeah.
We still have her, but man, that was scary.
She better earn her keep.
Yeah.
So Carlo asked about the coral snake. So the coral snake is not similar to the pit vipers at all. It is purely a neurotoxin. And once again, they're in the same family as cobras. And so the antivenom with crofab will not work for that one. Now, what we were talking about coming back to the Mojave was about the serpentologist getting bit by one, and how quickly, from what they consider to be a rather minor bite, that they started to have those neurotoxic symptoms. And once again, there is a lot of differences between coral and Mojave, mostly because Mojave is mostly a hemotoxin, but it does have some neurotoxin capabilities as well. And so that's why there's not that crossover between them. And if you look at those gas chromatographs, which they didn't show them to us, but if you look at the gas chromatographs, you're going to see that the protein profile of the venom is very, very different. If it were close enough to be similar, I'm sure that they would work on putting the coral snakes in there. The thing is, coral snakes, they have smaller fangs. They have to chew to get it to secrete the venom and to get it in far enough. And so, the bites are just so few. 100 a year, that's not that many. So as far as the exotics, okay, the thing is, there are venomous snakes, and please call them, if you're talking to a toxicologist, call them venomous, not poisonous. It's just one of their little idiosyncrasies. You make them kind of twitch a little bit, and so you don't want to do that. So there are venomous snakes in so many parts of the world, and you saw those gas chromatograph profiles. There is very species dependent protein profiles in those venoms, and so that's why if they get bitten by, say, an eyelash viper or a mamba and something else, there are so many different ones that you have to have the correct antivenom. And so you need to try to find out what the snake was. If it was not, if they tell you, most of the time these folks that keep these snakes know what they are. They're going to have something written in case they do get bitten. And then, they may, in some cases, actually have a form of an antivenom there with them. But a lot of times, if it's an exotic that's bitten them, you're going to have to go through a zoo. And if it's after hours, once again, your best bet is going to be to call poison control. and hopefully had that information. I was just looking through, and Wikipedia actually lists, and I was surprised they list by name the people in the United States that have died from snake bites based on the decade. And I noticed in 2010 to 2020 that they listed, I want to say it was 3 of the bites that killed people were exotics. Listed again their name and their age and the location that they were. And they showed one of them as having been a suicide. He had an exotic, and he killed himself with his own snake. And then the snake actually got away, but then got run over. So, what other question did you have there, Chris? Don't go and get one of these things. If you're going to get a snake, get a corn snake.
No, sir, it wasn't about that. But I lived in North Carolina for years, and in Wilmington, they actually did have a serpentarium, and the guy did get bitten. It was, I believe, a mamba bite, and he did survive, but it was very touch and go.
Yeah, and of course, zoos tend to have the exotics anyway. If you go to the Fort Worth Zoo, which is close to me, they have a really nice snake house, and they have probably 70 different species that are venomous. So, and it's clearly a risk with them. If you ever watch Crocodile Hunter, he talks about some of the snake bites that they've had at their particular zoo, the Australia Zoo. And so, but they also, those folks, once again, they tend to know what it was. I mean, they may have a little label that, writes out exactly what that is along with the species. Venom 1 in Miami is something to kind of keep in mind if you ever do end up with one of those. And they have been known to charter aircraft to fly antivenom to somebody that needs it. What else?
Quick question for you, Dr. Phillips, sort of multi-part. Saw, talk about the kid who died, saw a picture of a patient who was intubated at the beginning. So if we come on a patient who's at imminent risk of cardiovascular collapse from a snake bite, should we avoid succinylcholine because of the possibility of rhabdo and the potassium spike? Should we avoid etomidate because of the adrenal suppression? And then last, because I saw that exudate from the wound that you mentioned, is norepi our preferred pressor because it's going to clamp down and sort of decrease some of that vascular permeability?
Well, the bottom line with all of those is, first off, if it's an intubation, we're talking about a very brief duration, and really, other than somebody that is a renal failure patient where they can't clear out the potassium, I never hesitate to use succinylcholine. I like it because you're sure that it's going to come on in a minute. I've had a couple of times with vecuronium, even with the high dose vecuronium, that it takes a couple of minutes for them to really become completely paralyzed. So that's one consideration. The next, as far as you were talking about the accommodate. Well, accommodate in one dose, a single dose, really does not cause adrenal suppression. That is seen more in folks that are on it long term in an ICU. They're getting more than one dose. So if it's a single dose, I wouldn't worry about the accommodate for the sedation. Frankly, I prefer ketamine along with a paralytic because that way it's a general anesthetic agent and an analgesic. So, but whatever your system may not have that available, especially if you happen to be in Colorado these days. And then what was the last part of the question there? I'm trying to remember.
Would norepi be our preferred pressor because of the permeability in the vasculature?
Really, the phenylephrine also only has purely alpha, and so that's going to clamp down on the vessels, which may actually help to hold the fluid in the blood vessels. But norepinephrine works by clamping down as well, but it also has the beta effects on the heart. So really, any pressor is going to work, short of, say, probably I wouldn't use dopamine or dobutamine with it. But norepinephrine, epinephrine drip, phenylephrine drip, any of those should be fine. And you're going to be limited mostly by what your service has available.
Gotcha. Thank you.
Mm-hmm. Good question, though. Excellent question. What else?
Okay, folks. Good questions tonight. It was an excellent lecture. We appreciate it, Dr. Phillips. That was very knowledgeable, very up to date. I'll make sure this one gets posted.
Yeah, now the other thing, and this is just a little aside, I'm actually in the process of considering, and Jane, you'll know them well, I'm considering for Shackelford County trying to approach them about, should we go ahead and put like 4 vials on each of the ambulances there? Not in every system. And the reason is that one of the big problems with these snake bites is they call it dithering. So should I give it? Let's just give 2 vials. Let's give 4. No, let's give, well, and so, especially with the distances, if we have a definite envenomation, time is tissue. And so I would want to go ahead and get that started. Now, yes, it's a huge upfront cost for the service, and we're going to have to work out whether or not they can just be resupplied by the hospital and let the hospital charge the patient for that. But I'm kind of considering going ahead and having some CroFab put on some of my select units where they're more likely to encounter bites. But CroFab, if you're in a place like that, CroFab will actually exchange out expired doses if it's not too far out of date for fresh doses. And so that way, usually it's just going to be that initial cost up front. And if you work in a hospital where they're hesitant to stock it because of, well, we don't use it that often, they can contact CroFab and they will actually exchange those for newer doses if it expires. So something just to kind of keep in the back of your mind. And now I've got to try to, since the company that just bought them also has cyanokit, I'm trying to get them to do the same thing with cyanokit. Because that's a life-saving medicine. And I would like to see that on every ambulance if possible, just for smoke inhalation. So,
well, having worked in that area for many years, of course, it's been a while. Number one, you'll surprise me if you get it through the board there. And you'll surprise me even more if you get it through Hendrix. So, just let me know how that works out for you, Doc.
Well, I'll tell you how I approach a fundraising thing, and that is, local Lions Club having the officers handing us a vial of CroFab on the front page of the paper would look really, really cool for you guys if you could come up with, $4,000 to be able to get this for us. Wouldn't that really be great for you to be able to say, we're the ones that supplied that? I'm not above pandering to groups. Okay, so generally, the hospital, it depends. If you're a hospital-based system, then yeah, it would obviously be a hospital decision. If you're working in the hospital itself, then obviously it's a hospital decision. If you're in a private service or if you're in a third city service, then no, hospital wouldn't really have a lot of say over that at all. But it's a good question. The politics of medicine.
So may I ask also?
Sure.
Are hospitals, okay, so I live in Houston area, and we have like level 3, and then we have level 2s that we'll drive an extra 20 minutes to. Are certain level facilities required to have antivenom in supply? I mean, because I'm thinking transport decision, which facility, if that makes sense.
No, they do not have any mandate that they have to keep a certain amount in stock at all. And so, that's where you need to probably have that conversation ahead of time. There's an excellent resource that if you'll send me an email, or if you just simply go on to that, what snake is this, North Texas, there's actually a toxicologist down in your area that's kind of what most of his practice is snake bites. And so he would probably be the better one to tell you those sort of things. His name is Dr. Green, Spencer Green, and very approachable. He likes EMS. He's not an EMS physician, but he does like work. Yeah, I believe it is BioCity toxicology. And so, if you contact him, he can probably tell you in that local area their preferred facilities. And I'll just tell you that where I'm at, where I work in Texarkana, they still consider this a surgical disease, which if you say, talk about the surgeons to Dr. Green, he's gonna, you'll make him have a mini stroke probably. Thanks, Chris. That's great to see the link there.
I did have one other question up there. I'm sorry, I had Griffin for a second. He was getting a little fussy. But is there like a point where it comes where CroFab becomes non-effective? Like if you got a patient, and let's say they didn't seek treatment for 12 hours.
I don't know that there is a time limit, and the main reason is that sometimes this can be deposited into tissues and it slowly leaks out over time. And so I would say if there's a question, you simply call poison control. I do know one time when it's no longer indicated, and that is if the patient's dead. But I think that tends to be about the only time in a snake bite victim when they're going to say, don't bother giving the CroFab or any antivenom for an envenomated bite.
Thank you, sir.
Sure. Well, I don't think if there's anything else, I think that we can probably all go and get a good night's sleep, hopefully.
All righty. Thank you, sir. We appreciate it very much.
No problem. Thank you.
All right, folks,
Have a good night.
the next MD Roundtable is already scheduled for May the 5th with Dr. Frame. Dr. Phillips has sent me dates, but I was kind of waiting on Dr. Eschelbach and the new doc, Dr. Troutman, to give me some dates too, so I could balance everybody out for May. But I know for sure we have one scheduled for May the 5th on the calendar.
See, now Dr. Troutman was at the same conference with me last February, so I had
Really?
to beat him to the punch.
I'll tell him, don't do snake bites. Dr. Phillips just did it.
Yep.
All righty. Thank you. Good night, all.